Morning everybody. My name's Louise Winstanley. I'm the practice pharmacist team lead for the Fylde and Wire practices. So we have 20 practices that we've worked with, and we all have individual practices ourselves. So I work in one practice in Kirkham. There's my contact details there. If anybody wants to contact me afterwards, please do. Our approach really started in 2013, so we feel we're a bit ahead of the game, which is quite nice for a change. And I wanted to talk about a stepwise approach to increasing AF registers, increasing prevalence, so that leads to increasing prevalence, and validating the registers as well and how we did that. A little bit about how patients were identified, and making sure that it's very patient-centred care, so very much in conjunction with patients. Describing different practical approaches to improve the CHA2DS2-VASc and HAS-Bled scores, which only came into being really in the NICE guidance last year, and to increase the uptake of oral anticoagulants. Sorry about the short version, but OAC means oral anticoagulant. So in 2013, we decided that the NICE guidance was going to be due and there was a draft out. So we looked at that and decided that we'd try and do some work on it. There was a strong evidence base for oral anticoagulants versus aspirin. And we decided to apply the CHA2DS2-VASc scores in advance of more up-to-date information on the practice computers. We also calculated HAS-Bled scores for everybody and made sure the records were very robust. We used the GRASP tool to help us do this, and I don't know if anybody's familiar with the GRASP tool, but it's a way of identifying all the different read codes and all the different ways that somebody might be identified as having atrial fibrillation. So people not on the registers, and this is a massive number of people, so you can, it takes quite a long time to work through all that information and look at them individually. So we aim to identify our patient cohort and make sure people were on appropriate anticoagulation. So we did a baseline assessment, and the baseline assessment showed who was anticoagulated, who was on aspirin, or who was on nothing. And so we looked at each individual patient and reviewed diagnosis and management, and then came up with a list of people that we would review. And we invited the patients that were on aspirin or nothing to a clinic, a specialist clinic held in local GP surgeries. We had 10 AF clinics. We held them on Saturdays because that was the best time to see people. We didn't get a massive response, but we got a decent response. So we saw 239 patients. And at each clinic, there was a group education session about AF. So about 10 patients sat in a room and talked about the condition and stroke risk, and that was led by a specialist nurse. They then had blood pressure and pulse tests, and the CHA2DS2-VASc and HAS-Bled scores were recorded with the patient. It was discussed with them. And then they had an individual consultation with a cardiology consultant. Each patient spent approximately 45 minutes in total at the clinic, and these are some of the patient-reported outcome measures. And I think one of the main things were that people had not really understood the link between atrial fibrillation and stroke, so it's a bit of an eye-opener for them. And the patient satisfaction survey, you can see there, the results were really, really good, and anybody who attended really found it very, very beneficial. And I think they enjoyed both the time spent with them and also the availability of the consultant to discuss it in more detail in a relaxed atmosphere. And these were some of the outcomes that we had in 2013-14. We started off with the patients on the register on April 2013 were 3,106, and the prevalence was 2.3. By October 2014 were 3,341 with 2.45 prevalence. So we'd increased the numbers on the registered by 235. This was in addition to the clinics. There were two sides to the work, really. And so we got nearly a 9% increase in people on the registers. So we're really quite pleased with that. We thought, that showed, sort of a good outcome to that work. There is also a website, I don't know if anybody's seen it, it's called AF Infographic. And you can go on there and compare your area to either Lancashire or England, and I just went on it yesterday because when I looked at the prevalence, our prevalence is one of the highest in Lancashire, if not the highest. And compared to England, I think the prevalence is something like 1.47%. So we feel that we have really identified as many people as we can do, and we feel it's, you know, this is having an ongoing effect on our work now. So we managed to increase anticoagulation rates as well. The numbers pre and post clinic are there, and then at the end of each clinic the recommendations were sent to each GP practice for the individual patients for the GPs to action. And so at the end of the time we found that 36 additional patients had been added to AF registers and 40 additional people had been anticoagulated. And that doesn't sound like a lot, but the amount of work that went into getting that was quite incredible, really. So we had a rest last year and decided, we did antibiotics last year, so we decided to do AF again this year because we thought we could do some more. So the NICE guidance had been published, so that gave us a much stronger platform on which to push our work forward. And we felt that the numbers changed in 13-14 weren't that high, and we did have challenges with that. We felt there was a lot more to achieve. The GRASP tool, that, however, now showed that we had 54 expected strokes per year. So that's gone from 66 to 54. So again, we felt that that was very strong support for the work we'd achieved. Interestingly enough, the AF infographic works on the AF registers, not on the GRASP tool. And according to our figures on the AF registers, our expected strokes is 16. So again, that really, I thought that was a really low figure, and I thought that's possibly quite achievable. So that, again, that's given us a bit more impetus to make sure that we've done as much as we can. So we now knew that the registers were up to date, and we still were trying to increase anticoagulation and better management of AF. So this is where we're sort of here at the moment, actually. This is where we are. So the baseline search out of the 20 practices, I've only got data for 15, I'm afraid, at the moment, is 893. For all the practices, it's just over 1,000. And we've looked at it and split people down into various categories depending on all the different considerations that you need to think about when you're looking at individuals. So we have a group that are excluded because they're not suitable to be treated with anticoagulation. We've got a group which is a bit of a difficult group because they're on an antiplatelet for cardiovascular disease, and the evidence isn't really very strong about what we do with those people. We excluded a group of 109 that have a CHA2DS2-VASc score of 0 or 1 because it's not appropriate for them to be anticoagulated. We've got a group of AF resolved read coded, and again, the information around that isn't very robust, whether people with AF resolved should stay on registers but not be treated because they've had AF in the past. So that's an interesting discussion we could perhaps have later. We've got a group of people that have an end-of-life diagnosis and dementia. So we're going to revisit those to look at the degrees of, you know, the issue, because we didn't feel they were straightforward people to discuss this with. We've had to exclude a small group due to severe alcoholism, and we've got a small group currently under investigation with specialists. And then the other 3 groups in green, those were the groups we're tackling at the moment to offer anticoagulation to. And I just brought up some case studies, and my first case study is going to be a self-testing one, from what was said earlier. Only yesterday I had a patient contact me to say they wanted to self-test. So we have what's called the AHSN service, which is an extremely good service that manages self-testing with the patient. So I contacted the practice, I contacted the patient, and I contacted AHSN, agreed the strips were going to be prescribed, agreed for AHSN to contact the patient to explain to him how the process worked and how to buy the meter, and he went away a very happy bunny. So I'm glad to say he didn't have the same experience as the other patient. So, you know, if people want to self-test, I think it absolutely should be supported if the reasoning is right. And this particular chap's reasoning was that his blood levels were all over the place. He was having to go back for testing every week, and he wanted a measure of control for himself. So he'd already spoken to AHSN about it. They'd given him some information, and between us, it was very, very quickly managed. And you know, I've given him my contact number in case there's any problems in the future. So again, you know, very, very patient-centred care. Case number 1 is a 91-year-old lady with a CHA2DS2-VASc score of 5, so her stroke risk is 6.7%. Her Hasbled score is 3. She had an MI in 1993 and she's had ischemic heart disease since 1994. So would we start warfarin or a NOAC for this lady? Hands up for nothing. Hands up for NOAC. Sorry, NOAC means new oral anticoagulant. So that's apixaban, rivaroxaban and dabigatran. So NOAC or warfarin? Okay. There's a bit of a hint there actually. She was started on warfarin and she was also on aspirin. Now my concern here is, do we stop the aspirin and do we have any information that helps us decide that? I've put the wrong code, it's on the next page, next slide actually, but it's the BGH guidelines for oral anticoagulation, the 4th edition. That's the only paper I've found that gives you the bleed risk around these combinations. If anybody knows any different, I'd be glad to hear it. So her actual bleed risk of the combination of aspirin and warfarin is 5.1%. So I think we need to really think very carefully about how we treat a 91-year-old on 2 medicines that are going, you know, that give a high risk of a bleed. We've got the second one is somebody with new atrial flutter, waiting further investigations. The GP came to me and said, what do we do? What do we do? You know, we need to anticoagulate. I said, well, let's just work through all the numbers. So we did a CHA2DS2-VASc score, and she's 61 and female, so she has a CHA2DS2-VASc score of 1, which means she doesn't need to be anticoagulated. So his mind was put at rest immediately that we could wait till the investigations had gone through. And the third one is somebody with AF diagnosed by ECG in 2014 on aspirin, CHA2DS2-VASc score of 1, a Hasbled score of 3, age 62 and male. The CHA2DS2-VASc score is due to hypertension. So would we anticoagulate him? Hands up for yes. Hands up for no. Hands up for don't know. It's his choice. A male with a CHA2DS2-VASc score of 1, it's completely down to individual choice. So we would discuss that with him and we would give him that information. So it would be completely up to him. So we've identified 893 patients. We've got 152 to straightforwardly offer anticoagulation to, 17%. But we've got these other groups that we're not sure about. And added to that, most people, about 50%, will decline an oral anticoagulation, whatever you do. You know, some of these people we've spoken to 3, 4, 5 times. It's there all recorded on the record. And it's really, really difficult to get over that hurdle of anticoagulation. I mean, I think using the new oral anticoagulants has helped. People do seem to be a little bit more open to taking those other than warfarin because of the connotations with warfarin. So we think we're going to get, in this next group of work, is about 220 people anticoagulated, and the results are looking quite promising already. So, you know, I think the questions here are, how do we encourage people? How do we manage the risk both of prescribing and not prescribing? And we've got some more work to do. So we want to make sure that the National Patient Safety Alert on warfarin is actioned in GP practices, so that we can easily calculate the time to treatment range. So we're looking for people on warfarin within the treatment range of 65% of the time. And there are people that aren't in that range. So that's another piece of work that we need to do. We need to review the AF probables from the GRASP AF tool, because it gives you a lot of possibles and a few probables, so you need to re-review those people and just keep on top of looking at who is likely to be added to the register. Looking at oral anticoagulants for other indications, embedding pulse checks in practice templates, and also the Know Your Pulse leaflet. We've been using that for a couple of years now. We print off a lot of copies and just leave them on reception, especially around flu clinic time, and encourage people to pick them up when they come for the flu jabs, because it's an ideal opportunity if they're waiting in a line for a flu jab. We've also produced a folder for each GP practice. It's electronic as well as paper, with as many useful documents that we can find, and also the Lancashire Medicines Management Group. There are a couple of documents on there that are very useful for AF. Liaising with community pharmacies to make sure patients are aware of oral anticoagulants, and they're given the alert cards, and they're aware of what the practice systems are in relation to warfarin and the prescribing of warfarin. And making sure there's annual review and follow-up for anyone on a new oral anticoagulant, because in my area we haven't got a pathway for this at the moment, which does cause us a few concerns and problems. We've got a very good pathway for warfarin and for heparin, but not for the new oral anticoagulants. So in the summary, just to say we feel we've made lots of progress. We've had some very good results. We know that people are very reluctant to take oral anticoagulants and need clear information and reassurance, several consultations sometimes, and that time spent face-to-face and access to further advice is a key part of what patients need to be able to make the decisions. And we do need common ground for managing complex people. That still needs to be agreed and thought through, because sometimes we feel we've got as far as we can and we're not sure what to do with these other groups. So thank you very much, everybody.